Well, hello to Professor Hughes Marsh's class. She probably has you call her Lynn, but I'll call her that just in case. My name's Abe, and I just thanks for the opportunity to chat with you about some of the work that I do. Of course, this is a strange time for all of us, working a little bit differently. So I'm here at home, putting together this little talk for you. So you may, if you're lucky, have a chance to meet my bunny. She gets some free run time during the day, and so she's out looking for scraps on the floor right now, like a dog. Or my cat, though she doesn't. She's not really cuddly, so she doesn't usually bother me. Or my kids may ask tips on how you cut out a shamrock for St. Patrick's Day. So, but hopefully this will be a useful chat for you. Still, we won't be interrupted too much. So I'll just start by telling you a little bit about myself. I don't know what Lynn, or Professor Hughes Marsh, told you. Um, I am also a prof here at Western. I teach just in the graduate program these days. But I'm actually a Western grad myself. And so did my undergrad, my master's, my PhD here. And so obviously I'm purple and proud through and through, and really love our programs and really feel privileged to be able to be a part on the other side of the program now, and helping to deliver our courses. My background is as a community health nurse, and so I'll tell you some stories from that work. And in that, I worked a lot of my time at a health center for people experiencing homelessness, as well as a clinic for low-income families. And it's really those experiences, those stories, the people that I met through that work that have made me who I am, and made me passionate about the work that I do. And so I wanted to tell you a little bit about homelessness. I wanted to, kind of set the stage of what this is all about, and some considerations about what it means for your own practice, and what you can do about it. I'm sure in the program these days you've learned about things like health equity, like social determinants of health, vulnerable populations. And so to me, that's the life of my work. It's not theoretical. It's truly the stuff that I saw day to day was the impact of all of those determinants. I'll start with telling you a little bit about one of my first experiences pretty early on in my time at it's called the London Intercommunity Health Center. That's where I worked. So this was just just a regular summer day at the clinic. And I'd just gone upstairs. Someone asked me for a pair of pants, and we had a clothing kind of donation room on the upstairs. So I popped out of the clinic for no more than 5 minutes upstairs, and I came back down, and I was just greeted by this horror of blood. It was splashed all over the floor in the waiting room, past the exam rooms. It was on the furniture. So I jumped into action. I said, what's happened here? The social worker said to me, Anton has been stabbed. And it was Denise who stabbed him. She's gone now, and Dr. Harris is caring for Anton. So to be honest, I know, I wasn't surprised by this. Denise was one of our most troubled patients. She's really addicted to alcohol. And herself, she drank non-beverage alcohol. This meant mouthwash for her. And it's a common situation in someone who is so desperately addicted to alcohol. It's easier to get than beverage alcohol. It's easier to pick it off a shelf of a variety store or convenience store. And Denise was not only deeply addicted, but she was also a very angry person. Particularly when she was drinking. When she was sober, which was not very often, she was just quiet. But when she was drinking, she was mad. And so when I first met Denise, the other nurse who'd been working there for a lot longer than I had, she just told me, stay away from Denise. She hates men. She always has a knife on her. And so that was all the warning that I needed to stay away from her. But interestingly, over time, we did develop a relationship. It was a strange relationship. Sometimes she would just yell and swear at me randomly as I walked by, but other times she would actually tell me to sit down beside her. And through that time, she told me, bit by bit, over the months and years together, the story of her life. So she grew up, she's First Nations, she grew up on a reservation just outside of London. She had two older brothers, mom and dad, who both kind of did odd jobs for the council on the reservation. When she was 9, her mom's drinking started to become pretty problematic, got worse and worse, to the point where she would kind of disappear for days at a time. And so her dad, by the time she was 10, basically, her dad was taking care of all the kids. Unfortunately, at that time, her dad began to sexually abuse her. That went on for a year, and then when she was 11, her older brother also began to sexually abuse her. By 12, she started drinking, and at 13, she ran away from the reservation and she came to London, which is, there's a lot of flow back and forth between our First Nations communities and the city of London for many reasons, for school, for work, for housing, what have you. And so I met her. When I met her, she was 43 years old. And so she had not been sober for about 30 years, so except for, the odd stay in jail. And so, no surprise that she hated men. No surprise that she kept a weapon on herself. So anyway, back to that day, what had happened was the two of them had been sitting together, and Anton had made some advances on her, and she had told him to leave her alone. And after several warnings, she pulled the knife out of her boot and she tried to cut his throat. Luckily for him, instead, she just ran the knife right around the edge of his jawline. And so that's why there was so much blood. And so actually all he needed was stitches. And she was found by police not too far down the road. And she went away to jail for about a year. She would have gone for longer, but Anton wouldn't testify for pretty obvious reasons, for his own safety. So it was my time working at the Intercommunity Health Center and really hearing the stories of people. It's really their stories that have changed my perspective, and really seeing some common themes through those stories. So those would be things like childhood neglect, family poverty, trauma, violence, substance misuse, poor access to community supports, and fundamentally at the root of it all is the drastic increase to housing costs. So one of the questions that I often get is, well, don't people choose to be homeless? And in my mind, they don't. It's these traumatic and horrifying life histories that create, along with problematic public policies like inadequate affordable housing, that create homelessness. So I would say no one chooses to be homeless. Right now in London, we see some of the highest rates of rough sleeping that we've ever seen, meaning people out in tents, people in parks. And so people say, what should we do about this? And some of what I hear back to that question of what should we do about it is basically, well, there's nothing that should be done. There's shelters, there's welfare, there's jobs in our city, so people should just kind of get themselves together. And so there's that presumption there around a choice that if they're sleeping out in the parks because they want to in some way or another. But you don't have to work very long in this sector, even in an emergency room or a medicine unit, to see that there's a lot going on that's far beyond personal choice. One of the aspects I think that we don't talk about enough is that idea of developmental disability, for example. A huge proportion of the people who I work with at street level are living with traumatic brain injuries and disabilities from birth and just don't have the intellectual capacity to take care of themselves. They've done some research on homelessness and traumatic brain injury, and found a rate of 53% of people experiencing homelessness, and this is Canadian statistics, having a traumatic brain injury. And so folks definitely might struggle with just the capacity to take care of themselves. They may not be able to work for life. They may be temporarily out of work, but they may be permanently not able to work. And so when I think about like when future times people are looking back at our history and how things are right now, I really think that society's going to judge us on this. They're going to say, how could we in our day and age have let people be homeless who just couldn't take care of themselves because of disabilities? So that choice idea, that's a myth. And so one of the things I wanted to do with you in this video is talk about some of the common myths and misconceptions around homelessness. There's 6 of them I really want to tackle. So the first is that idea of choice. And so actually the other thing that happened is there was a research study here in London that was looking at mental health, that was looking at how people transition to and from mental health hospital out in the community, because this is kind of historically has been one of these cyclical paths into homelessness, is from long-term psychiatric stay. And so one of the questions in their survey that they asked was they asked people's desired housing. And guess how many people on that survey? They surveyed about 200 people. Guess how many picked homelessness as their desired housing? Yep, 0. This is not surprising. People don't want to be homeless. Rather, it's this interplay of complex, traumatic personal histories and experiences, and structural factors, like I mentioned, that make people homeless. All right, so second myth is that homelessness is just a big city problem. And I know many of you probably come from smaller communities. I know lots of our students come from the county, places close to London like Strathroy and St. Thomas, but also places further away up in Grey Bruce or out towards Sarnia. And you may not see the kind of street homelessness that you see here. It just looks a little bit different. And so to understand, there's my bunny, come to say hello and check out my garbage pail for anything tasty. To understand kind of the differences, we have to understand the definition of homelessness, because there is this perception around homelessness just being those who are, absolutely sleeping rough on the streets. But actually, there are 4 different types of homelessness within the Canadian definition that we talk about. So the first is that absolute homelessness. The second is emergency sheltered, though, because folks who are in a shelter are on a time-limited stay. In London, for example, it's a 30-day stay that they're allowed there. So it's not permanent. They're not paying the rent to be there, though it does come off their social assistance income, a certain amount. And so they're not housed. It's just a temporary shelter. Then there is what we refer to as kind of those in alternative accommodation, which might be people who are sleeping in places that are not designed for human habitation. So they might be crashing in an abandoned building or something like that, or couch surfing, or in a motel, or trading sex for a place to stay. And then the fourth is what we call hidden homelessness, which are folks who may be, again, kind of provisionally accommodated through non-official ways, so they don't have a lease in place, but someone is letting them exchange some cash for a limited period of time. And so that's kind of what we see in rural communities, is that hidden homelessness. So far more kind of couch surfing, far more kind of provisional accommodations, but it's still out there. So the third myth is that mental illness causes homelessness. And you're probably like, at this point, thinking like, how is that a myth? Because you don't have to look too far to realize many people experiencing homelessness are also experiencing a mental illness. So absolutely, for sure, and the rates they vary. Depends on the population who you survey. So in a general population that comes through emergency shelter over the course of the year, it's about 35% will be experiencing a mental health challenge. If you look at chronic homelessness, though, that rate goes as high as 80, even into the 90 percentile. So there is a definite correlation between mental illness and homelessness. However, mental illness doesn't cause homelessness. And I say that because the vast majority who experience a mental health challenge in their lives will not become homeless, right? So many professors in this fine institution experience mental illness. Many of our students experience mental illness. And for the vast majority of us, we get treatment, we get maybe medication, maybe counseling, supports from family, maybe we need to take a bit of time off of work, and we get into recovery. But for some few individuals who also usually have other complex life circumstances, other maybe histories of trauma, maybe live in poverty, other challenges around determinants of health, that becomes part of a pathway into homelessness. So it's not that the mental illness causes homelessness, it's that mental illness in the context of other things puts people at a higher risk of homelessness. And to me, that's an important message because it gets us back to the idea of public policies and how can we actually ensure that everyone has the resources that they need so that if they do get into trouble, if they have a crisis, that it doesn't cause them to become homeless. All right, myth number 4, people just need to get a job. And oh man, so I do a lot of speaking on this issue in all sorts of different environments. So not just academic settings. I speak to business groups, community groups, conferences, all sorts of stuff. And this is the thing that I get most often, right? Is that like, well, maybe like once unemployment gets better, that people will, that homelessness will go away. And maybe what's the economy, if we can make the economy strong. There is a small correlation between the economy and homelessness, which usually has more to do with things like access to affordable housing. But the vast majority of people experiencing homelessness are not in a situation where they are what I would call employment ready. So that because of the complex things they have to do in their lives, right? So women might be experiencing intimate partner violence. And that's getting safety and safety planning and reorganizing their lives and divorces and that sort of thing is far more important than their employment at the moment. Or as I mentioned, people may have developmental disabilities that make them permanently struggle with employment. They might have mental illness and temporarily be out of employment or an addiction. Or what have you. So employment programs as a solution for homelessness, they do help a select group of the population. There are always folks who are in shelter, a few folks in shelter who it's like a job loss situation, they've run out of their EI benefits, etc. But that is a minuscule amount. And if we wanted to think about policies that improve homelessness, we'd be far better to look at our social assistance, like our welfare, Ontario Works, Ontario Disability, and just increasing those each by a couple $100 a month would have way more positive impact on ending homelessness than having more job creation programs. All right, myth number 5. This is similar kind of to the one around mental illness, is that everyone who is homeless is a drug addict. And there's kind of an underlying message in that myth, right? Which is like, if we can say everyone, who's homeless is a drug addict, there's like a therefore they deserve to be homeless is kind of what people are often implying. Of course, most wouldn't say that out loud, but that's kind of what they're trying to put across. And so to look at this issue, actually, I like to use the example of youth. And so youth and perceptions around youth homelessness and substances, I think are pretty flawed. And so we have great data on youth homelessness, much of that from here in Canada, in Toronto, with some pretty large studies. So the vast majority of youth who become homeless have never used any hard substances prior to their homelessness. However, the vast majority of youth who remain homeless for 6 months or longer have subsequently used a hard substance. So, rather than substance use causing homelessness, homelessness causes substance use to a very high extent. The more there's like a growth over time, so the more someone is chronically homeless, the more they're at risk of exposure to substance use, which then can make it harder for them to exit homelessness. Which is why part of what we're talking a lot about right now is both prevention and then rapid exits from homelessness to stop some of those negative patterns. So why does that happen? Well, substances are medicine. Some of them are literally used as medicine, and they help. They help someone with physical pain, but they also help people with psychological pain. And so when you're living in the trauma of homelessness, then you find a substance that helps you feel better. Of course, you're going to use that and continue to want to use that. And so addiction's an illness. Addiction is something that we put people at risk of when we let them become homeless. And we shouldn't judge folks for that, because we don't judge folks for any other illness. And last, myth number 6 is that homelessness is a failure of the individual. And so in our society, we like to think about, these ideas of like, everyone can make it if you work hard enough. You can get what you want in life. You see this like, I don't know if folks are on Facebook anymore these days, but my generation is. And there's always like gobs of these Facebook memes of like, work hard, set a good pathway, and you can achieve whatever you want to achieve. And so in that context, again, that idea is that homelessness is somehow a choice or a flaw of the individual. So let me tell you about another patient. Let me tell you about Jeff. Jeff was one of the kind of most known individuals in our community. He used every service for people experiencing homelessness, and he used those a lot. He had high rate of addiction, lots of medical issues. He needed a lot of help. And so he was like every morning, 9 a.m. when I opened the front doors at the health center, he'd be right there ready to come in. And so I actually, this instance though, I bumped into him at somewhere else at a coffee house, because as a nurse, I did some shifts around other community spaces to reach out for folks. And he looked pretty beaten up the one morning, was bruised and whatnot, and he was favoring his shoulder. He was kind of holding his arm in. And I asked him what had happened. He didn't really remember what had happened to him. He thinks that he had been assaulted by some folks. Who knows, he may have fallen. He may have been struck by a vehicle. I literally watched one morning out the window as he stumbled across Dundas and got slow motion hit by a car. So who knows how he actually got injured. But when I asked to look at his arm, the injury was very obvious right away. So his shoulder was rotated inwards. And you don't have to be an orthopedic surgeon to see this and know that he's broken a collarbone. So I said to him, I know you hate hospitals, Jeff, but you need to go in and you need to get this checked out. So he went into the hospital. They had a look at it and x-rayed, and it was actually not just the shoulder, but the arm was broken as well. Orthopedic surgeon came down for the consult, said, yes, we need to do surgery. You need plates and screws, but you're intoxicated. So 2 options, you either come back sober or you sit and wait here till you sober up, and we'll do the surgery. And so Jeff, unfortunately, does not do sober. And so he took off. And about 2 weeks after that, so actually I didn't see him for a little while at the health center. And the other nurse bumped into him at another community facility. And she had a look at it, and still bad. And this time, though, he said, I can't move my fingers anymore. And so they sent him to the hospital. They had a look at it, and the hand was mottled, no movement, no feeling. Orthopedic surgeon said, you've lost circulation, the hand is dead, we have to amputate it. Although he was intoxicated, they brought him straight into surgery and amputated the arm. First, it was a series of amputations because he got some subsequent infections. He ended up ultimately having it amputated above the shoulder. And so, to me, this raised a lot of questions about our system and the fact that the amputation could be done while he was intoxicated, but they couldn't flex the rules to actually do the repair of the arm in the first place and actually save his hand and arm ultimately while he was intoxicated. And I use this example because I think this is a really good illustration of that idea of personal choice versus our systems and our policies. And in a lot of ways, our policies are not equity oriented, and they don't flex to meet the unique needs of unique and vulnerable populations. And so I would say it was as much us that cost him his arm as he did himself by being intoxicated. It was solvable. It was fixable. The policy change would be very simple, is that in a case where someone is chronically addicted, then the risk of respiratory distress related to giving someone an anesthetic who is already intoxicated is a lower risk than the fact that they will just never receive treatment if we wait until they're sober. Simple solution, and would have saved him an arm. So this gets me back to this idea of choice and what I said earlier about our shame of our nation today will be that we let developmentally disabled people sleep in tents in our parks, sleep in basements. So my last story on this issue is another individual who I'll call Art. Art also very well known, attending kind of every meal program, every drop-in center. And he acquired a brain injury at birth, and so he had a hypoxic event during the delivery and was left with this moderate intellectual disability. So he's lived in all sorts of group homes, supportive facilities, right from birth. He's 48 when I worked with him here in London. But he'd also ended up in and out of shelters. Both parents deceased, so he is cared for by the state in a way, as in that he has a public guardian and trustee to pay his rent and that sort of thing. But he also has relatively high autonomy and independence because of his condition is moderate. But he does have some behavioral challenges with some activities of daily life, like general personal hygiene. So what happens sometimes is he gets in conflict with his workers. He'll just leave. May have a home in a supportive facility, but he'll just take off and he'll go to shelter. So everyone likes Art. They work with him, but they also find him very frustrating because he doesn't kind of do what he's told to do. So, I mean, the question is, like, what do we do with folks like Art? How do we make sure that that he can be safe? So, I mean, we could, like, appeal to the courts that he's an extreme physical risk, and then the public guardian trustee would also become in charge of decisions about his personal care, and so they wouldn't just manage his money, but they would tell him, "Thou shalt live here," kind of deal. But he isn't really an extreme physical risk. If he shows up with shelter, we can just reconnect him again with disability associates who take care of his supportive living facilities, and hope to get him back into care. But I think there's a concept here that is so important. And to think about this concept, actually, which is this concept of autonomy, choice, balanced against people's personal safety, it's great to look at what's happened in mental health care. And so one of the things that I hear in around homelessness, and people will literally, they'll DM me and they'll say, "Hey, there's this guy, I've seen him out near Grand Ave behind an apartment. He's clearly psychotic. Can someone check on him? Because they know, I work in this area." Or we'll be out having drinks on a patio in the summer, and someone will walk by and they'll be obviously psychotic, and my friends will comment like, "Oh my gosh, like this person should be put into care," right? And so there's this kind of like sense of horror of like, oh my gosh, people are psychotic, people are mentally ill, and they're wandering around in the community, and like shouldn't we put them into like a facility? Shouldn't we institutionalize them? Shouldn't we like lock them up and make them safe? The challenge is that was what we used to do. And not we, I mean like generations before us. But institutionalization was the initial response to mental illness. And so everyone got locked up for centuries and centuries and centuries. If you were ill, you got locked away in like an asylum kind of model. And it was more like confinement rather than treatment, right? So during the 1900s, we had the human rights movement, human rights around LGBTQ2S, human rights around race, around gender. And we also had human rights around mental illness. And that idea at that time was, well, hold on a second. We can't just lock people up because they have an illness. That's not right. And so we started to kind of wrestle with this balance that people can make decisions for themselves. And as long as they're not a direct risk to their own safety or the safety of others, that if they want to choose to walk around talking to themselves in public, that's their right, that's their choice. If they start to be sick or something, or they're not eating, or they're actually like shove someone, then suddenly that choice changes, right? Because now they're a risk to themselves or others, and then the state does force them into care. But there's a lesson in this that I think helps us understand about art, and the fact that with a moderate disability, that we have to be careful about not imposing ourselves. On the other hand, not giving up on him, right? So because he does walk away from his facility and go into shelter, that's his right, but we also know that he doesn't have the full capacity. So it's our responsibility to assertively reach out to him and say, "Hey, you're not in shelter, what's going on? Can we find you a better option?" And maybe he tells us to go fly a kite. That doesn't, again, mean that we give up on him. It means that we come back the next day and say, "Hey, how are you doing today? What are the right supports that can help you?" And so I think generally, as we think about housing first, that we have to think about that idea of the individual's autonomy, but then also not giving up on people just because they're difficult, just because they are hard to work with, right? And that's really the balance that we, as nurses, we need to strike in the care that we provide. So I wanted to tell you, to kind of close off some of my talks, about models that are actually proving to be promising in terms of helping people who are homeless find better health and well-being. And one of those is this idea of housing first. And so that might be terminology you've heard already. But housing first is that idea that traditionally in our housing and homelessness services, we used to require that people would kind of go through a staged process before they would get housing. So they might have to comply with treatment. They might have to, do some kind of hoops to jump through. Housing first says actually, if we just get people as quickly as possible into stable housing, they then actually are more successful on those things like accessing treatment, because it's really hard to care for yourself while you're homeless. And so that's the model that's kind of driving practices in our community right now, which is, trying to make that experience of homelessness as short as possible, really looking at permanent housing solutions, and then tying supports into those housing solutions. So I think that's what someone with like Art needs, right? Is he needs that support to say, okay, we'll get you a new apartment, and then we'll reach out to you. We'll touch base on a daily basis and see where you're at and what you need. We're not going to abandon you because you've walked away from an option, right? We're going to provide you with another option. Tomorrow we'll try again. So we've seen that to some level of success in our community. So we've seen programs where folks, like Jeff, are rehoused finally after like 20, 30 years of chronic homelessness. We've seen their health outcomes totally turn around. The big challenge we have in our community right now is that we just don't have enough affordable housing. And on the second side is we also don't have enough supports. And this is, again, where I say that homelessness is not a choice of the individual, it's a choice in society. The best way that I can illustrate that is by thinking about the US, Canada, and Finland. Relatively similar countries, right? Pretty close economically, fairly close in terms of our histories, like in terms of when we became industrialized, very close even geographically for us in the US. However, fundamentally different rates of homelessness. Canada has a rate of homelessness 10 times that of Finland. The US has a rate of homelessness 10 times that of Canada. I'm no mathematician, but I'm pretty sure that means the US has 100 times a rate of homelessness as Finland. Now, like, are Americans, Canadians, Finns that much different than each other? I don't think so. I mean, I think we're more same than different. What's different is our political and social structures. And so in Canada, we have very limited public housing. In the US, they literally sold off their public housing in the 90s. In Finland, they never stopped creating public housing. So that factor alone, the factor alone that the government commits fully, partially, or not at all to public housing, creates a drastically different rate in homelessness. And that's what separates our countries. It isn't personal, it's choices that we as a society make about how we structure our social systems. So, to me, as a nurse, that's what pulls me into doing policy work. And so I love the work that I did. I can tell you a million more stories about the patients who I worked with and how interesting and fascinating and challenging and sorrowing and inspiring that work was. But really, what I spend my time on these days is on doing research to create policy change. And so I try to create knowledge that we can use to fundamentally alter our system so that we can do things like adequately fund our public housing services. Because as a nurse, to me, my work pulls me deeply into the social determinants of health. And so, yes, there's lots we can do to help people one-on-one, and I hope when you experience working with someone who's homeless in a hospital setting, in a community setting, wherever, that you provide them excellent personal care, that you show them deep levels of respect, that you don't blame them for the illnesses like addiction and mental health that they might be experiencing. However, I also hope that you become an advocate. I hope that you find ways that you can tell those stories and elevate those stories up to decision makers so they can make the best decisions to create a society that actually eliminates homelessness. So I think as nurses, we have to think micro and macro. We have to think micro at the level of the patient. We have to think macro at the level of the policies that are creating the challenges that our patients are facing. So on that, I will close my comments for today. I've got so much other things I could say about being a nurse and working with people who are homeless, but I just wanted to give you kind of an overview for now. And what I know is that Professor Hughes Marsh is opening a discussion or a chat where you can post questions. Really look forward to seeing those questions. I will answer, each and everything that comes my way. So please do provide those. And, if there's tons of them, I might make just a follow-up video, or I just might write out those answers as well. So anyways, thank you for choosing an amazing profession. Thank you for being good humans. Take care of yourselves and your loved ones during this difficult time that can be stressful. And, don't touch your face. Oh no, I probably have somewhere in this video. I'll go wash my hands. So thank you all and have a lovely day.